Welcome back everyone. In this video we'll look into some symptoms of schizophrenia in detail, mainly hallucination and delusion. I hope you remember this slide from the previous video. As you can see, delusions and hallucination are positive symptoms, which means that they are behavior excess or additions. As you know, hallucinations are one of the hallmark symptoms of schizophrenia, and auditory hallucination are the most common type of hallucination in schizophrenia, typically occurring in over 70% of the patients. These hallucinations involve hearing voices, sometimes described as individual voices, multiple voices, or even other sounds like music or footsteps. The voices can be derogatory, threatening, or profane, contributing to the disease and a sense of external control. Over time, patients may develop coping strategies, question the content, or even establish a relationship with their hallucinatory voices. Okay, next is auditory verbal hallucination. Command hallucinations are common, occurring in up to 3/4 of patients at some point of time during their illness, and these hallucinations involve voices commanding the individual to perform certain actions. Compliance with these commands is more likely when the voice is believed to be real and has benevolent intentions, or is perceived as powerful, or is congruent with the patient's delusional beliefs. Visual hallucinations are less common than auditory hallucinations, occurring in approximately 1/3 of the schizophrenia patients, and these hallucinations can involve various images such as people, religious figures, animals, or fantastic creatures. They can be colored or in black and white with varying degrees of duration and clarity. Some patients may also experience visual distortions or illusions like shadows appearing as people. Olfactory, gustatory, and tactile hallucinations are very less frequent, and tactile hallucination involves a sensation of touch or discomfort or under the skin, and it occurs in 15 to 25% of patients. Olfactory hallucination, which involves false perceptions of smells, and gustatory hallucination, which are related to taste distortions, are reported by a very small minority of patients. These sensations can be distressing, ranging from feeling touched, burned, or cut to experiencing sexual assault by unseen entities. And the influence of culture on the content and sensory modes of hallucination can be seen, with certain culturally appropriate variations observed in non-Western societies. It emphasizes that hallucinations are not exclusive to schizophrenia, as they can occur in other psychiatric and encephalopathic conditions. It is important to note that the experiences of individuals with schizophrenia can evolve over time, and coping mechanisms may develop in these people experiencing them. Delusion, like hallucination, are key features of schizophrenia and are often described as fixed false beliefs. They are characterized by a strong conviction and resistance to contradictory evidence. Karl Jaspers, a German psychiatrist and philosopher, emphasized that delusions arise from a unique kind of experience, a direct experience of meaning distinct from normal reasoning. Delusion in schizophrenia can be flexible, and they may change with the life circumstances or shifting attention. Some patients readily accept that their delusional concerns are unfounded. Delusions exist on a continuum with normal beliefs, and they can develop from everyday cognitions, often arising from social stressors, particularly threats to self-esteem. The distinguishing factors for delusion in schizophrenia are the frequency, preoccupation, and distress they cause, rather than unique content or structure. The most common delusion in schizophrenia is the fear of persecution. Delusion may also involve thoughts of being controlled, thoughts of being audible to others, or unusual significance attributed to neutral stimuli around them. Bizarre delusions, once considered critical for diagnosing schizophrenia, are now less emphasized as their presence varies across patients and is not exclusive to schizophrenia. Delusions often develop as attempts to explain hallucinatory experiences which may be otherwise incomprehensible. Complex hallucination may lead to more elaborate and internally consistent delusions. Separating hallucinations and delusions in clinical settings has limited utility as they are closely related symptoms in schizophrenia and tend to change together. Delusions remain a treatable symptom of schizophrenia, and their impact on behavior depends on the individual and the specific theme of the delusion. While it's debated what exactly underlies delusion, people with schizophrenia and delusions tend to make decisions based on less information and with greater confidence than control groups, indicating reasoning errors in delusion formation. Delusions in schizophrenia can also result from a rush to judgment and are often associated with cognitive deficits. Negative symptoms in schizophrenia are often underestimated and underappreciated but have a significant impact on disability and social functioning. Negative symptoms are characterized by a loss or diminution of normal functions and are distinct from positive symptoms which involve the addition of abnormal mental functions. Historical perspectives on schizophrenia highlighted emotional and deterioration and loss of interest as central features, but an emphasis on treating hallucination and delusion led to the neglect of negative symptoms. And the publication of DSM-3R and subsequent diagnostic criteria acknowledged the role of negative symptoms in schizophrenia, with diminished emotional expression or evolution included as a characteristic symptom. Negative symptoms are relatively stable over time compared to the positive symptoms and disorganization symptoms and have been present but unrecognized throughout the history of modern diagnostic criteria. T.J. Cow's two syndrome concept, differentiating positive and negative symptoms, has driven research into negative symptoms, leading to the development of assessment tools like PANS, SANS, SAPS, etc. Negative symptoms are not unique to schizophrenia and can be observed in individuals with brain injuries or even mild form in the general population. However, they are more common and significant in schizophrenia itself. Demographic and clinical variables including gender, premorbid functioning, earlier onset and longer untreated illness are associated with significant negative symptoms. Negative symptoms are more heritable than psychotic symptoms but less heritable than the disorganization symptoms, and they play a crucial role in distinguishing schizophrenia from other psychiatric disorders. Negative symptoms represent a specific domain of psychopathology and should be considered separately from cognitive deficits, even though there is a modest correlation between them. There is a consistent relationship between negative symptoms and disorganization symptoms in schizophrenia, with both showing an increased familial risk. Negative symptoms correlate with measures of neuropathology, especially related to the frontal lobe function and cerebral tissue volume. The Metrics Consensus Conference in 2005 identified five general categories of negative symptoms. They are avolition, anhedonia, social withdrawal, affective blunting, and alogia. These symptoms can be grouped into two main categories: avolition symptoms, which indicates a loss of drive and pleasure, and affective blunting symptoms, which indicates reduced emotional expression and verbal communication. Avolition refers to the loss of will or drive to initiate and persist in goal-directed activities, often leading to deficits in work, intellectual pursuits, and self-care. It is closely related to apathy. Anhedonia is the loss of the capacity to experience pleasure and take interest in activities or relationships. It is persistent in schizophrenia and should not be confused with depression. Anticipatory pleasure rather than consummatory pleasure is significantly reduced in anhedonic individuals. Social withdrawal includes indifference to social relationships, a decrease in the desire for social interactions, constricted relationship with family and friends, and difficulties in experiencing intimacy or closeness. It is associated with deficits in theory of mind. Affective blunting involves an inability to recognize and express emotions. It predicts functional impairment in schizophrenia and includes deficits in emotional expression, facial expression, gestures, and prosody in speech. Men, individuals with early onset illness, and those with poor premorbid functions are more likely to exhibit affective blunting. Alogia refers to decreased verbal communication, or it's commonly called poverty of speech. Okay, it involves a loss of speech production such as increased latency to respond short verbal responses and paucity of spontaneous speech. Alogia is considered a negative thought disorder, while the paucity of meaningful content with normal speech volume is a disorganization symptom. Poor attention, previously considered a negative symptom, is often more related to disorganization symptom than negative symptoms. These categories of negative symptoms play a significant role in the disability and functional impairment associated with schizophrenia. Negative symptoms in schizophrenia can manifest at various stages of the illness. Anhedonia and social withdrawal can even predict the development of schizophrenia in high-risk populations. Initially, these symptoms may be overshadowed by more dramatic symptoms like fear and psychosis, but a range of negative symptoms can be found early in the disease itself. Anhedonia is particularly common at the onset, with avolition and affective blunting also frequently present. Recognizable akinesia, difficulty in initiating motor activity at first admission, can indicate an increased risk of subsequent significant negative symptoms. These symptoms can progress during the early years of the illness. Negative symptoms have diverse sources, including iatrogenic causes, long-term institutional care, or a subsistence level existence can remove normal pleasures and reinforcing activities contributing to negative symptoms. Antipsychotic medications can also induce a phenocopy of primary negative symptoms. Reports of excessive antipsychotic doses causing blunting of affect, diminished motor activity, grooming and hygiene impairments, and anhedonia have existed since the early use of neuroleptics. Positive symptoms such as hallucination and delusion can cause apparent apathy, social withdrawal, and alogia. Secondary causes of negative symptoms may remit within a year of their onset, distinguishing them from the primary negative symptoms. Negative symptoms can be part of symptom exaggerations in schizophrenia, and their severity may parallel an increase in positive symptoms. Antipsychotic medications can help reduce negative symptoms when treating positive symptoms. Overall, the cause and expression of negative symptoms can vary from one individual to another, but the prominent negative symptoms at onset can be better predictors of the future course of illness than levels of psychotic or disorganization symptoms. The primary negative symptoms are intrinsic to the disease process in schizophrenia and are persistent throughout the course of illness, as discussed earlier. Their persistence predicts future disability also. People with schizophrenia and the deficit syndrome, characterized by enduring primary negative symptoms, have poor prognosis. They tend to have lower quality of life, more time in hospitals, increased symptomatic periods, and more social and physical anhedonia. Individuals with the deficit syndrome have lower intelligence quotients, less education, work histories are very deteriorating, and less likely to be married. It is more common among men and associated with an insidious onset, progressive negative symptoms, and poor response to medication or social skill training. The deficit syndrome does not necessarily involve more severe delusions or hallucination, but it is marked by enduring and problematic negative symptoms. Accurate assessment of the deficit syndrome depends on special training and the use of the schedule for deficit syndrome. While the deficit syndrome affects a minority of people with schizophrenia, its prevalence varies with estimates between 10% and 30%. Rates tend to be lower early in the course of illness and increase during the first 5 years. In clinical practice, distinguishing between primary and secondary negative symptoms can be challenging due to time constraints and resource limitations. The concept of persistent negative symptoms have been proposed for cases where possible secondary negative symptoms do not respond to standard remediation methods. The criteria for persistent negative symptoms include a diagnosis of schizophrenia, at least 2 negative symptoms present during periods of clinical stability for at least 12 months, and not attributable to comorbid psychiatric conditions or medication effects. Emphasizing the potential for extrapyramidal symptoms to cause negative symptoms, these criteria aim to highlight an under-recognized issue and help allocate clinical resources more effectively. That's an end to part 2. We'll be discussing other symptoms like disorganized speech, motor symptoms like catatonia in the next part of the video. Thank you for listening.